Okay, excellent. Okay, well, welcome everybody. Thank you so much for joining us for the Stanford Medicine Center for Improvement lecture series. Today we're very fortunate to have as a speaker Dr. Katie Brown-Johnson, who will be speaking to us on, the title of her talk is The Lightning Report Method, talking about rapid qualitative assessment and getting stakeholder feedback. For those of you who have not joined before, we welcome you to the speaker series. We're delighted to host individuals from both Stanford and external to Stanford who come to share their wisdom, their experience. Sometimes we talk about things that are of interest, current events, or people are sharing what they're planning on presenting and getting feedback and stimulating a discussion. So really that's what we hope that this will be. Katie will present her content in basically the first half, and then we hope to have a robust discussion afterwards. So please do take notes and jot down some of your ideas, your thoughts, your questions as we go along. And if you could be prepared to have that discussion, it makes us a lot better experience. Also, we see some of you on video, which is fantastic. We recognize not all of you are in a place where you can share your video, but if you are, it's really helpful for Katie and for all of us to be able to see each other, even if you're eating. I think we have, Katie, are you okay if people are eating, if they go ahead and continue to share their video? Yep, I'm seeing a head nod there. So if you are able to share your video, that would be great. Okay, so with that, let me just provide a brief introduction for Katie, and then we'll hand it over. Again, Dr. Katie Brown-Johnson is a social research scientist with the Division of Primary Care and Population Health Evaluation Science Unit. She's a co-investigator of Presence 5, supporting provider presence approach to support rapid quality improvement. She's interested in teams, motivation, anchors her work in evidence-based science. I'll say she is a regular faculty member for our advanced course in improvement science, as well as our clinical effectiveness leadership training, gets the day started for all of us in ensuring our presence and complementing, accentuating our efforts in quality improvement. So with that, thank you so much for joining us, Katie, and we'll turn it to you.
Great. Thank you so much, David. And for those of you who were here when we got started, I said that I was wanting to give off a treacherous vibe because of my background. Not at all true. What I want to give off with the lightning report method is the idea that this is something that you can do. This is something that you can try out and see what works and what doesn't work with your clinic, with your institution, with your interventions. And I may be hearing some background noise, but I can't find it, which is fine. And it may be background noise from my house because the kids are about to head off for their half day of school. So I am Katie Brown-Johnson. I am probably the only linguist that you will meet, a PhD trained linguist that you will meet in a school of medicine. I'm in the Division of Primary Care and Population Health at Stanford, and part of our fantastic evaluation sciences unit. And I really just want to share the evaluation sciences unit team. This presentation is a joint endeavor. The lightning report method, it's a joint endeavor, and I just want to acknowledge our team. We focus on high quality, coordinated, patient and family-centered care. And really, and you'll see this with the lightning report, it's really about embedded healthcare delivery and partnership with our clinical partners. And just to spell it all out, big picture before we dive into the lightning report, starting at the top left corner, we're really trying to bring the academic rigor to, and moving to the top right, to clinical capacity building. And we do that by really focusing on relationship building, and that includes providing rapid feedback for innovators, so that clinical innovators can really focus on quality improvement, innovation, and do what they do best, and have our partnership to help level things up a bit. Oh, one more thing before we dive all the way in. I just want to invite you. I'm happy for you to take notes. I'm happy for you to go ahead and post your questions in the chat. I obviously won't be responding to them while we're talking, but I'm happy to go back and look at chat questions, when we start our discussion, if that's a good place for you to keep things. So today's conversation, our contents will talk about introduction, what is a lightning report, and learning objectives. I want to take a step back and talk a little bit about stakeholder analysis and qualitative methods more broadly. And then we will dig into a step-by-step how-to for the lightning report. So what is the lightning report? This is, lightning report, it's a fun name. It's just a fun name that we came up with to reflect how fast we're trying to provide feedback. And what it's really looking to do is marry methodological rigor with a rapid qualitative feedback cycle. So we hope that it helped prospectively evaluate dynamic system implementation. And really part of it is about prompting communication with stakeholders. And you'll see that our healthcare partners are woven in at the pre-planning stage, in data collection phase, and then also in our finalization phase. We wanted it to be about immediate actionable insights, which are super important in the dynamic systems of, can you guys still see me? You guys can hear, oh, good.
Yes, we can see you.
You guys.
We can hear you, but
you guys can, no worries. You can hear me, but everything's frozen. It'll come back on in a second. And
Katie, we just lost your presentation.
Okay, I'll get it back up as soon as I'm reconnected. I think it's just my Wi-Fi, which is why I've got myself on the phone for audio, so that there's still connection as it's cycling. It should come back on pretty shortly. So with the lightning report, it's really about the immediate actionable insights, the methodological rigor. There you guys are. Let me share my screen again. Here we go. Is that giving you the right thing, the lightning report
Yes.
introduction? Great.
Looks good.
Thank you. Okay, fantastic. So this is what a lightning report looks like. And well, like I said, we'll dig into it in a little bit, but I just wanted to give you a sense of, what we're going for. It's a, 1 to 3 page max document. It's really meant to be easily consumable, and it's intentionally designed in a way to have any stakeholder be interested in interacting with the information. All right, so our learning objective for this workshop, so by the end of this workshop, we are hoping that you would be able to create a lightning report based on rapid feedback received or collected during the implementation of an intervention. And I know that might be a big step for many of you, but I'm hopeful that this would get you in your first movement towards that. So let's talk about stakeholder analysis. So when you're thinking about quality improvement, obviously you're wanting to identify and understand the problems first. And I think, part of the concept of this, we want to think about, how can you best understand the problem and rapidly inform implementation and adaptation. And it's the rapidly informed implementation and adaptation. Things are not sagging. We've definitely seen in this last year things are not static within healthcare. They don't, healthcare pauses for no one is maybe the best phrase for this year. So we need to understand what's going on. And this is really where your stakeholders come in. And I'm gonna, I'll say right now, I am, I'm a biased person with respect to this. I'm a qualitative researcher. And so I'm really going to be pushing administrators, I'll be pushing clinicians to go talk to patients, talk to patient caregivers, talk to your staff, your medical assistants. Without your staff and your medical assistants, any quality improvement, or most quality improvement projects won't move forward. They're really key in all of this. And identifying the stakeholders is really about identifying the key individuals or groups that you need to talk to that might influence the intervention outcome. And there may be groups, if you're working, if this is really thinking about a healthcare setting. If you're working on community partners, you may have other stakeholders in different spaces that you want to be thinking about as well. So let's think a little bit more about qualitative methods. In the context of dynamic systems, we really think that qualitative methods are best suited to inform implementation and intervention adaptations. You're not going to get the best information necessarily from a survey if you're in, week 1 or week 2 of an intervention. You really want to be able to hear, and I'm giving away a little bit of the lightning report here, what's working and what needs to change. And I just wanted to pull, this qualitative methods comic out. This is an exaggeration, but I think a lot of it is about being curious and non-judgmental. So the qualitative researcher says, and what did you feel when you saw the free ice cream? And our participant says, excited, a little scared. And of course, there's a good follow-up question as a qualitative researcher. And why was that? Tell me more. So a qualitative approach really gives you the flexibility to incorporate, and I'll show you the different kinds of methods, incorporate observations, incorporate interviews, incorporate a lot of data from a lot of different spaces into the work that you're doing. And then there's lots of different ways to analyze qualitative data. We are going to focus on rapid assessment procedures, and specifically the lightning report. So these are really pragmatic approaches to addressing the need for timely and contextually rich feedback. Really thinking about supporting adaptation, redirection in this dynamic clinical setting. And this is where we can think about, would interviews be best? Is it best to talk to get on the phone and call some patients and hear from them? Or, I've definitely done some quality improvement evaluation where, prior to COVID, where I sat in the waiting room and just chatted with patients ahead of time before or after their visits to get their perspective on, team-based care or something else that we were interested in. So let's focus in on the lightning report method. So the lightning report method, it was originally designed as an engagement tool for our healthcare partners. And so we had this need to communicate with partners, number one, as we were wanting to build trust, and number two, as they're looking for feedback, as our clinical partners are looking for feedback about what's going on with an intervention or a redesign. generally, it's too early for a full analysis. Maybe we haven't talked to everybody, or like I said, this intervention has been in place. This improvement project has been in place for 2 weeks. It hasn't fully caught in, but we're looking for some information about what's working and what needs to change. And so that's really what this is. That is using the structured plus delta. And for those of you that are familiar with Lean or Six Sigma, that's the manufacturing-based performance improvement methodology that is really widely used in quality improvement. Plus delta is going to be really familiar with for you. We've added the insight for the lightning report method, and the insight is really just that's the eyeball. The insight is really just a catch-all for insights or ideas that stakeholders have when you're talking to them, or insights and ideas that you have as somebody who's hearing from a bunch of different people about what's going on. And so, after we sort of had this rapid feedback approach in place, we wanted to make sure that that it was something that people would want to engage with. And so we built the lightning report, and it's intentionally an attractive, well-designed report so that any stakeholder might be interested in engaging with it. And that's, all the way from administrators to, hopefully patients, if you were able to get feedback from them. So let's do a step-by-step of how to do the lightning report method out in the field. And I think the 3 big pieces are, number 1, pre-planning, number 2, your data collection and synthesis, and then 3, the lightning report creation. And I pull these out because they each have different, different reasons that they are important. So, with pre-planning, this is really within your own team, with your relevant stakeholders or your evaluation partners. You want to think about, we want to hear about what's working and what needs to change, but what are the other things? Is there anything else that we want to hear about? And this, again, is a really nice way to build relationships with, between research and clinical partners, because there may be other things that that partners are interested in. I think, for instance, with a team-based redesign, primary care 2.0 with Stanford, they were at one point really interested in the nurse practitioners, and so we added nurse practitioners as a specific, area of inquiry. So you pre-plan as a group, and then researchers or a couple of people, implementers, go out, into the field and talk to people. And you're going to be talking to your stakeholders. Data collection and rapid synthesis. I say the first thing is really structured research notes. And for me, that literally looks like I'm putting a plus, a triangle for delta, and the insight across the top of a page of paper, and jotting things down in those notes in that structured manner. Ideally, you would have 2 people who are doing interviews and talking to people, or at least 2 people that get together and discuss the notes and memos. And that's a really important validation step that provides some of the important rigor to this process, where you, so it's not just one person's interpretation of what's going on. And then you're synthesizing findings as you go, doing sort of the analysis synthesis into the plus, delta, and insights. And then the last piece is lightning report creation, and we'll go through a little more detail with that, and I'm keeping an eye on time. I should back up pretty shortly. And you want to circulate to stakeholders within a few days after data collection so that they can inform the next round of data collection and help finalize the lightning report. So major areas of the lightning report, the executive summary, these are 3 to 5 bullet points. You really want this to be, if someone reads only this, you know, what are the 3 things that you want people to know? And I just want to show you this at the top. We feel like it's really important, especially for your, you know, your administrator, people who want to be looking at this report. And then you can add the sample and methods, and I'm going to go lightly over this. But this is really, you know, how many total interviews, what kinds of people were you talking to? This is where I like to use colors. And colors are just really helpful for having people be interested in engaging with the material. And then finally, there's the synthesis of findings, the positives or the plus, perceived facilitators and what works, and then the changes that are needed. And I really like to talk about it as changes needed instead of what's not working, because changes needed, built into what needs to change is the idea that change is possible. And so there's an intentional motivator within the change language instead of the what's wrong language. And that lives kind of down below. So just wrapping up here, you know, our discussion, I think discussion points we could think about, you know, how could the lightning report method facilitate quality improvement in your department or clinic or institution, and what facilitators could enable your group to implement the lightning report method. And I can stop sharing my screen or keep these questions up. But I'll turn it back to you, David, for facilitation.
Well, thank you so much, Katie. I love the brief presentation of your lightning report. So you, I think, practiced what you preached there and put it out there with plenty of time for discussion. So I'm going to have lots of questions and lots of thoughts, but I want to make sure that we open it up to others with questions or thoughts. So maybe I will, let's see, I'm looking in the chat. Nothing has come through in the chat yet. So please feel free to put something in the chat or we'll call on you. So if anyone wants to jump in, we can look if you want to raise your hand. And if not, I'm going to start us off with a couple questions. So I'm not seeing any hands raised yet or anyone chiming in. Oh, wait, Lisa. Okay, well, here we go. We're starting to come in the chat. Great. Okay, so Jennifer's asking whether the slides will be available and the recording, and I'm seeing a nod from Katie.
I believe the nod was me nodding about the chat questions. I think Lisa is the right person to ask about whether the recording will be available.
Sure, we'll have the recording and the slides up on our website. Thanks.
Perfect. Okay, so I see a question from Bob. Why don't we start with Bob Turbo? You want to kick us off?
Oh yeah, hi everybody. Thank you for the wonderful presentation. I was wondering about rapid cycle improvement and just sort of if you can contrast it with something that's maybe more out there in the literature. This is new methodology for me.
Mm-hmm. Can you hear me now? You should be able to. Okay, that's a great question, Bob, and my internet is cycling again, so I'm back on the phone momentarily. You know, a rapid cycle is really focused. I think we're focused on some of the same things. You know, I think the rapid improvement cycle, in my understanding, is focused on primarily focused on the you know, improving what's happening with the intervention or with the, you know, with the quality improvement. And I think the lightning report is doing the same thing. I think what I get excited about with the lightning report as a methodology is that it does provide an additional step of rigor that maybe doesn't change how, doesn't differentiate in the short term about how it's used in terms of providing feedback. But for instance, as a researcher, I've been able, with lightning reports over time, I've been able to go back and look at the trajectory of an intervention, or compare across different groups or different interventions from an improvement or an implementation science standpoint, and get a sense of, what are facilitators across the board looking like, or what are the barriers that are specific to different contexts. So I think that you're right that there's a fair amount of overlap. I think there's also overlap with user-centered design, and I think that the differentiating piece for the lightning report is this ability to stand between the feedback of getting things done and the potential for a longer term research grade assessment of what's been going on. Does that answer your question?
Yes, it's an issue of really first impression for me. It also seems like rapid cycle improvement is often about system improvement, socio-technical, and this seems very people focused, and I say that in a positive way, that understanding the culture of safety issues underlying it. So this seems to be very much based on human interaction, and I'll go ahead and mute. Thank you very much.
Absolutely. Absolutely, and I think that's the kind of overlap with user-centered design, is that it is focused on the stakeholders and stakeholder perspectives. David, do you want to call on somebody next?
Yeah, we've got a very robust chat going, and we've got a couple people with their hands raised, so we've got lots of discussion coming up. So Marcella is asking if we can get an example or a scenario. Marcella, do you want to say any more? It sounds like maybe something a little more concrete to help us visualize it. I don't hear Marcella coming off mute. So maybe, Katie, if you want to speak to maybe some examples, so just some kind of concrete applications for where you've seen this work well.
Yeah. So we've used it in a number of places. Most recently, I think we were really interested in working with our ICDP, our colleagues in ICDP. And forgive me, it looks like my internet has gone to Rainbow Town, which is the rainbow circle for Max. I'll check back in with my internet shortly, but I'm glad I'm on the phone and chatting with you guys. Most recently, we used the lightning report to hear specifically from patients about a transition from inpatient to outpatient dermatology. And we were really just saying, for this process, what works, what needs to change. And I was really interested, and we didn't talk to very many patients. We talked to 15 total patients. And even with that number, we were able to provide some insights to the team that are, help them think about how they're going to structure an intervention that helps smooth that. And just a specific example was this idea that, some patients going from inpatient dermatology to outpatient dermatology were intentionally not following up with the outpatient dermatology appointments because they had other more pressing healthcare issues to tackle first. And with that seems kind of straightforward, but of course, as a dermatologist, you're focused on how can I help this person as a dermatologist? How can I make sure that I'm seeing them quickly enough? And so being aware that there are other factors involved in the broader care of an individual is really useful. And another example, and this is the one that I had up on the screen, was looking at scribing intervention in primary care 2.0, and I saw Marcy Levine, who is our primary care 2.0, one of our primary care 2.0 champions, and also the lead for the test clinic, where we looked at primary care 2.0. And so, with that, we saw what was working, what needed to change, and then some of our insights with that were things like, these people who are medical assistants who are taking notes, not all of them, but some of them are, were able to listen to the conversation, identify a need, especially around insurance, and be on the computer looking that need up and figuring that out so that they could then turn back to the provider-patient conversation and say, hey, it looks like this, with your insurance, that this prescription may be delayed. Do we want to have a plan for that? So that's like an example of the insight that we found in looking at this kind of stuff. I hope that answers your question.
Yeah, Marcella said that her audio is malfunctioning, but hopefully you captured that. Basically, what I'm hearing you say, Katie, is anytime you need rapid insight, but reasonably rigorous insight and representative insight from your stakeholders, this is when you can use it, right?
Absolutely. Yes. Yeah.
Great. I've got a couple more questions in the chat, and then we'll go to Megan, who's got her hand raised. So Marcy asked the question, how do you do this in a way that will make sure that staff, for example, will feel safe to speak honestly?
Yeah, so this is where it's really nice to work with the Evaluation Sciences Unit as an outside group. So we are trained, I'm not the only qualitative research scientist, and we also have trained master's level and other PhD level qualitative researchers. When we come in, we can say we're not going to share this in a way that would be identifiable. And the ways that I like to do that are, if I have less than 3 people in a group, so 2 medical assistants, I might say that I've interviewed them, but I'm never going to say something like medical assistants reported X, Y, and Z, because that would have the potential to identify people. The power dynamic is real and something to pay attention to. I would say, when that's not, when it's not feasible to have somebody external come in and help with this, then the things to do are to make it less scary and a safer space are to not record, to say I'm not going to record this conversation. I just want to take notes. To have existing positive relationships, with your staff and existing feedback mechanisms that allow for staff and for folks who have less power in the system to feel comfortable, and then just to be really careful to put your judgment and your really put your curiosity cap on and put your judgment cap in the drawer for while you're talking to people. And I'm happy for any of my team to chime in on other thoughts, either in the chat or if you want to jump in.
Okay, we'll look for them in the chat then, unless others want to jump in real quick. Again, lots of great discussion. Dawn is asking about focus groups. Can this be applied to a focus group?
Absolutely. So I focused more on interviews because I wanted to, streamlined for somebody who, oh good, and I can see you guys again. Yay, for somebody who, who might, this might be just the first time they're coming into this, but you can really do this with any sort of qualitative data. So focus groups for sure. Observations are, a nice way to really see if it's a system that's happening that or a process that's happening. Observations or having somebody walk you through all of the steps. So I think that this is my hope is that this is a flexible enough approach that you could use it for any type of qualitative data.
So Megan has her hand up. Megan?
Yes, hi, good afternoon. Thank you, Katie, for this really excellent presentation. So my question is centered around selecting quality improvement projects to work on. So I lead a team of well over 50 frontline healthcare providers, and there's never a dull moment in terms of where we can improve our quality or initiate quality improvement projects. And so as I'm watching this, I'm wondering if there might be using this tool as an opportunity to survey what would be worth putting our time and effort towards. So just wanted to kind of hear your thoughts or comments on that, and if not, what you would recommend.
Yeah, I think I love that idea. Thinking about it as a needs assessment tool, and what's working and what needs to change. It's definitely applicable to thinking about what are the priorities for for quality improvement. I think our team is working on a set of principles around how you decide which quality improvement projects are best suited for a research boost, or for additional rigor, which is not exactly the question that you're asking, but I think the things that we consider with that are, how can it be evaluated? Do we think we're going to see a change? How are we going to see a change? We also think about the partners and who, do we feel like the folks that we would be partnering with are going to be able to get this done, both, because of who they are and because of, the tangle or not of what they're trying to tackle. And we've got other factors that we're thinking about too, from a research side, things like, with a brief review of the literature, is there anything in this space already? In which case, we might or might not be more interested in working on the additional rigor. And then what is this going to contribute to the institution and the field? And I guess my reflection on all of that is just, it is nice to have a rubric in making those kind of decisions. And I do think that you could use the lightning report as a first step in a prioritization process.
Great, thank you.
Katie, Lisa had a question about what kind of training qualitative researchers should have, or I guess what training you would need to be able to do this. Lisa, did I capture that right?
Yes, and I was also curious if ESU or your division, Katie, had any kind of a primer that was available.
Yeah, I think it's definitely a good idea. So worst case scenario, if you're about to start an intervention and you haven't talked to anybody, just go talk to people. And get some feedback. It doesn't have to be super structured. That's not going to be qualitative data, but it's just so important to get stakeholder input, as I'm sure you all know. When we start to think about qualitative data and qualitative training, you do want to have some basics around, protecting your participants' confidentiality, around how to ask open-ended questions, things that give people a chance to broaden out their thinking instead of funneling them on a specific path. And those are like two of the basic things. And sometimes it's just nice to have some experience with it. We have a qualitative, like a 4-hour course. That's a qualitative analysis course that we offer from time to time. We don't have a primer per se, but we're working on pieces of training. So things like interview, focusing specifically on interviews. I'd love to have a piece like I was saying about, thinking about power dynamics and confidentiality. And then there are books as well. I'm always a fan of Creswell, which is, if you want to go in and read a full textbook on qualitative methods. So there are lots of good places to start, and I'd be happy for folks to start by contacting us for sure.
Great, thank you. If it's okay, I have a couple of questions. One is, you do these interviews. The reality is that there is there's a distribution, shall we say, of opinion or thoughts. How do you make sure that you both capture, that distribution, and also make sure that you don't kind of get hung up in one opinion or a minority of opinions that doesn't really represent the more broad opinion?
Yeah, this is a great point. So I think this is really where it's nice to have a second interviewer or someone to debrief with. On the front end, it's important to have that. And then on the back end, it's important when you've finished the draft of the lightning report that you take it to your stakeholders, at least to the implementers or the champions of your, whatever your quality improvement project is. And what you can do in those two spaces is say explicitly, I perceive this one way, or I saw this big risk, but not everybody mentioned it. How much should we highlight or toggle down this this piece of it? And when I'm thinking about it, so when I'm thinking about it from an institution perspective, I want to talk to my institutional liaison. I want to talk to my clinical partner and say, this is what I've seen. Should we go back and get more data? Do we need to hang on to reporting on this until we've talked to more people? Or, is this not relevant, et cetera? So really working closely with them, with my, more of my research hat on. Really, anytime I'm making a statement about, what people have reported to perceive, I want to also think about what, if I have any negative or contra evidence, so that I can say something in a manuscript like, some people thought this, a minority of people disagreed in this kind of way. And that's really when, a manuscript might be when you really have more space to elaborate. Or if you're doing, if this is a presentation and you're able to have a conversation with, administrators or medical assistants or, whoever you're getting to present to.
Excellent, thank you. Real quick, the book you mentioned, I think that's Qualitative Inquiry and Research Design, Choosing Among 5 Approaches by John Creswell. Is that the right one? Okay.
Yes, yes.
Okay, we'll put a link to that in the chat. Then there's another question by, let me go back up to it, Neil, who's asked a specific question about the evaluators. We have 2 evaluators. Do you want them to do those interviews separate or together? Neil, anything you want to add to that?
No, that's just was curious to know, is it better for sort of having independent interviews so that you get two perspectives in terms of the way the questions are asked, or is it actually good to have both evaluators in the same interview so they can kind of parse the same answers maybe differently and discuss that?
Mm-hmm. Yeah, I think there are benefits and risks to both approaches. Typically, what's been happening with me is I might have a more junior person who's working with me, and they hadn't been out in the, they've been trained, but they maybe haven't been out in the field all that often. And so in that case, I'm really going to want us to do a few interviews together, just to make sure that everybody is kind of on the same page, that we're thinking about things in the same way, that we, debriefing afterwards. And debriefing may be a fancy way to say a coffee break, but it is really important, so debriefing afterwards to see, like, are we seeing the same thing? Are we seeing things that are different before we can kind of go off and conduct our interviews separately, and know that we're kind of asking the same things. I can see an approach where either for, with respect to resources or time, that you're not able to do that, in which case you would just want to make sure that there is a debriefing mechanism and a way for interviewers who are asking separate questions to think about how to fold that data together, fold the information together.
Thank you.
So, Katie, we have a ringer, it looks like, in the audience. Barbette is asking how to differentiate this from formulative evaluation or action research. Barbette, do you want to expand on that at all?
She might have had to leave, David. She might have said that.
Yeah.
So I think, like I said before, with the with other types of research, like this really straddles a lot of different things. So for instance, with participatory action research, the insight category comes directly from that. It comes from work that I've done previously in youth-led participatory action research, which is related to community-based participatory research, which is related to action research. So, I think it's definitely pulling on that lineage, and also on the formative evaluation, where you are, formative evaluation, you're looking. You don't know what the answer is going to be. So you're really, you don't even know necessarily what your question is. You just want to talk to people and get a sense of, like, what's going on. So I guess the differentiation between formative research and a lightning report would be that I think you're a little farther along in your stage of intervention. And for the, the action research piece, that's often involving the community in some way. And I think I tend to think of our community partners as being outside of healthcare. And it's not as often that those groups are being involved in this lightning report approach, although they could, and it could be part of action research, but currently as it's used, not so much. So that's like, fine hairs. But, I think I tend to think a lot about how pragmatic an approach is going to be. And I think pragmatically it does, like Megan was saying, there are a lot of potential uses for it, and it's meant to be flexible enough to be able to tailor for specific situations.
So, Katie, maybe my next question somewhat builds on that. When, for most types of reports, we have some version of where we start with kind of a background. We walk through the methods, the results, and our interpretation or conclusions or discussion of the results, right? And so you can even, even like a SOAP note does that, right? We have a subjective portion assessment, so the data are presented. and then some assessments and something moving forward. When I look at this action plan, one thing I'm not sure of, help me understand, can I look at this to back up to say, wait a minute, how did you draw those conclusions? What is your underlying evidence to then say, okay, you convinced me? Or, if I look at this, I wonder if it could be just jumping more to the kind of that assessment portion. And I don't know as a reviewer if I can really make sure I go back, if I don't trust it, to see, well, what was the basis for your conclusions?
Mm-hmm. Yeah, so I think this is maybe where it's really important to include actual quotes as much as possible in the plus delta insights. We don't include an introduction or a setting. We really go straight in for like, what's the high level executive summary, and that is, that's intentional, but that I think that also, it is a standalone document, but I think it's really meant as a standalone document that then somebody says, tell me a little bit more about this. So it's maybe a little bit more of a hook, and less of like fish food. Just to have a really awful metaphor in the middle of things. And so as a qualitative researcher, when I look for evidence, I'm looking for what did people actually say? Does this seem to line up with what with what the conclusions are? And so you do have risks where you've talked to 5 people. It's not very many people, and for whatever reason, it's a good time to roll up a lightning report, and then you just make sure that you identify, in the sample section, 5 people, like the N is 5, and so there's ways to indicate, where things are very solid and where things might be a little more fuzzy in the report itself. But I think you raised a really good question that I want to think more about how to shore up the lightning report based on your feedback.
Well, thank you, Katie. I think we're approaching the top of the hour, and it would be great if we can give people a few minutes before their next meeting. Any final thoughts before we wrap up?
Thank you so much for being a part of this. And I'll just say again, as a qualitative researcher, I just encourage you to talk to people, talk to your patients and your staff and your administrators, because that's the first phase of all of this. So thank you so much for your attention and for your interest.
Well, thank you, Katie, and thank you everyone for participating today. I'd like to emphasize how much we appreciate our collaboration with all of our partners across Stanford Medicine. As you can see, the Evaluation Sciences Unit has yet again delivered just a wonderful concept and engaging opportunity. So we do encourage people to reach out directly to them if they have that chance. So again, we thank you all for your participation in today's session, and we hope to see you next time. Lisa, any other thoughts before we break?
If you haven't joined SMCI, go to smci.stanford.edu and join today. Thanks.
Excellent. We'd love to have everyone as a member at the appropriate level. Thank you again, and have a wonderful day, everyone.